wanted to ask you, very, very nice, and I wanted to ask you, what is your opinion of combining, you mentioned the attempt to combine multiple immune therapies, R2, R3s, but I think that there is a lot of opportunity out there to combine targeted therapies and immune therapy. So what's going on in that space, and how do you see it? Because it's no-brainer that if you are combining targeted therapies with immune therapies, you could avoid the drawback of suppressing the immune response, which is inherent in chemo, or maybe less so in radiotherapy. But anyway, what is your view? Because I think that there is a tremendous opportunity, totally unexplored as yet. Well, you were saying that the previous meeting was targeted therapy and the next meeting will be immune therapy. Maybe the 2018 will be combination of.
Well, of course, that's as regards targeted therapy. I mean, when the first breakthrough came with imatinib in CML, then everybody was saying, well, now that's it, we have found a solution. And then it was realized that CML is an outlier, where we have just one chromosome abnormalities, whereas normally we have dozens of chromosome abnormalities. So you need to combine a lot of targeted therapies. And there are a lot of attempts ongoing to combine targeted therapies, and also already some attempts to combine that with checkpoint inhibitors. I must say that up to now, to combine targeted therapy has proven to be more difficult than expected, because well, everyone will say, well, let's forget about chemotherapy, it's toxic and so on, and then it was all of a sudden discovered that sometimes combining targeted therapy is more toxic than chemotherapy. So it's not so easy, although we know that we have to move in that direction, but perhaps Cancer Mouse Hospital will help us in devising these combinations.
Yep. Probably the role of patient stratification should be reconsidered in this type of trials, because you're giving rituximab to all the patients with the same disease. The only
the current problem I see is that at least the pharmaceutical industry is drifting towards this idea that now we have the blockbuster drug again because immune checkpoints are pervasive. And what I keep saying is that no, you need robust stratification. And if you have robust stratification, maybe you can combine, by the way, targeted therapies with immune therapies, and not too many, maybe the one that may work, No,
when I talk about cancer to the lay public, I always say there will never be the penicillin of cancer. And I think this is that, well, we have to learn how to combine the different weapons, and this is the only way to go forward. I completely agree.